Welcome back from the break, everyone. This session will be presented by Dr. Corinne McLeod and Dr. Doreen Chung. Dr. McLeod is a board-certified OB-GYN and assistant professor at Albany Medical Center. She attended medical school at the University of Texas Health Sciences Center at San Antonio and completed her residency in OB-GYN at Albany Medical Center. She practices full-spectrum OB-GYN and sees patients of all ages, genders, and sexualities, regardless of disability or insurance status. Dr. Doreen Chung is a urologist in New York, and is affiliated with multiple hospitals in the area, including New York Presbyterian Hospital, New York Presbyterian Columbia University Irving Medical Center, James J. Peters Veterans Affairs Medical Center, and New York Presbyterian Allen Hospital. She received her medical degree from the University of Toronto Faculty of Medicine and has been in practice for 14 years. Dr. Chung takes lots of different insurances. She is one of 158 doctors at New York Presbyterian Hospital and one of 9 doctors at James J. Peters Veterans Affairs Medical Center who specialize in urology. She has more than 40 publications and over 450 sightings. And they both have experience with complicated issues and complicated patients. So thank you, Dr. McLeod and Dr. Chung, for joining us today.
Good afternoon, everybody. As Dr. Tiagi mentioned, my name is Doreen Chung. I actually haven't worked at the VA in very many years, but I do work at Columbia Presbyterian and the Allen Hospital, which is now known as the Spine Hospital for the past couple of years, and New York Presbyterian Westchester, which used to be known as Lawrence Hospital. I specialize in neurourology, voiding dysfunction, and female pelvic medicine and reconstructive surgery. Today, I'm going to talk to you about bladder management and sexual health in women with spina bifida. So first, we're going to speak about bladder management. Spina bifida patients tend to have problems with the following issues: incomplete bladder emptying, urinary incontinence, recurrent UTIs, upper tract, meaning kidney damage, and stones. So first, in order to understand how these problems occur, it's important to understand how the bladder works. For bladder filling, there has to be a good capacity, meaning your bladder has to hold a good amount. It has to be elastic and stretch at a low pressure. In order to be dry, also, the urethra must remain closed. In order to empty well, there needs to be a good coordinated contraction, meaning a good squeeze of all the muscles together, and the urethra has to relax in order to allow the urine to exit. There are many different bladder patterns in spina bifida patients, as well as many different patterns in spina bifida symptoms in general. There can be an overactive bladder with an overactive sphincter. These patients have urinary incontinence with incomplete emptying. You could also have an underactive bladder with an overactive sphincter. These patients just have incomplete emptying. You can have an overactive bladder with an underactive sphincter, which leads to urinary incontinence, often with complete emptying. And you can have an underactive bladder with an underactive sphincter, leading to urinary incontinence with incomplete bladder emptying. Overall, this leads to 2 main problems: urinary incontinence and difficulty with bladder emptying. The goals of management have been set by various associations, and they are the following. It's super important to protect the kidneys. Spina bifida patients a while ago used to often suffer from kidney disease, which often was one of the leading causes of death. It's also important to be dry for most patients. We try to have patients be independent as much as possible. We also these days try to avoid major reconstructive surgery unless it's absolutely necessary, and sometimes it is. It's also important for patients' quality of life and overall health to avoid or reduce the frequency of symptomatic urinary tract infections. So how to protect your kidneys? It's important to have periodic visits to your urologist. Usually the urologist will order periodic ultrasounds of the kidneys just to keep track on how they're doing, as well as some blood work to see how your kidneys are doing. Baseline urodynamics testing at some point is very helpful, or if there are any changes in urinary function, And it is overall important to try to avoid UTIs, particularly kidney infections, although some UTIs are definitely just normal. This is a picture of a patient undergoing urodynamics. This is a test that we do to basically query how the bladder works. We put a tiny little catheter into the bladder to measure the pressures from the bladder squeezing or the pouch, a tiny little tube into the rectum or vagina to measure the pressures from the patient pushing. We fill the bladder to see how big it is, how elastic it is, whether it's overactive, what causes leakage, and how well it empties. From this information, we can gather a couple things. We can figure out why a patient's leaking, why a patient's not emptying, and as well, if their lower urinary tract might cause problems with the kidneys. So overall, the most common bladder issues in spina bifida patients include incomplete bladder emptying, urinary incontinence, these two we mentioned before, recurrent UTIs, upper tract damage, and stones. We will talk about each of these separately. So treatments for bladder emptying, let's talk about that first. So many patients have difficulty emptying, even through adulthood. When patients are younger, very young, they often have a vesicostomy. But as patients are older, there are a couple options. Suprapubic catheter is one option. The majority of patients are on clean intermittent catheterization. Some patients do clean intermittent catheterization through a catheterizable bowel channel. And there's also urinary diversion. I'm going to go through each of these options. This is a picture of a patient with a suprapubic catheter. This is indwelling, meaning it stays in place. You can either attach it to a bag, or this patient has something called a flip flow valve. So basically, there's a little tap that can be opened and shut every couple hours. Some people instead cap and uncap, meaning there's a little stopper that they take in and out. Overall, this tube needs to be changed every 4 weeks. For some patients, this is temporary, and for some patients, this is a permanent option. This picture shows different types of clean instrument catheterization. Clean intermittent catheterization, which many of you do, I'm sure, means passing a catheter into the bladder every couple hours to empty the bladder. This can be either through the urethra or through a bowel channel for some patients. So how to do CIC well? Many patients do CIC and some people don't get infections and some do. So these are just some instructions on how to do CIC to help to avoid to get infections. First of all, wash your hands with soap and water or hand wash. Put on gloves. This is optional. Some patients need to do this to prevent infections and some people don't. You need to wipe the area to be catheterized with iodine, chlorhexidine, or Castile soap wipes. Next, introduce the catheter, making sure not to touch the tip with your fingers. Empty the bladder, discard the catheter, wash your hands with soap and water. So tips for doing CIC. If you meet resistance, do not push. Instead, reposition the catheter and try again. There definitely are times when, for some reason, the catheter is not quite in the right position and is sitting on the wall. If one pushes, this can create what's called a false channel. And over time, if that false channel gets bigger, sometimes that needs to be repaired. Some patients don't empty all the way due to the shape or size of their bladder or pouch. So at times, one must move the catheter in and out a little bit in order to fully drain the bladder or pouch. There are lots of different types of catheters. Many of you may know about these, and some people are just using the catheters that they've always used. There are telescoping catheters, meaning these are small catheters that can expand by pulling on them, sort of like a telescope. There are closed system catheters where there's a bag on the end. This is sometimes more convenient for patients, but also often does help with preventing infections. There are coated catheters, which already have lubrication on them. This is very helpful for not having to carry around lubrication. And some patients need what are called a coude catheter, where the curve is present. And this often helps if, for example, the patient has bigger labia, it helps to find the urethra easier. Here's a picture from the Sick Kids website of a bowel channel or metrophenol for catheterization. In this case, the appendix is brought to the skin and the appendix leads to the bladder. So one would place the catheter through this channel into the bladder and empty into here a jar. So next, let's talk about urinary incontinence. There are two main types of urinary incontinence, but many types overall. Stress urinary incontinence is leakage with exertion, sneezing, or coughing. This happens in all patients, whether or not they have spina bifida, particularly women in general. In general, urinary incontinence, urgency incontinence is leakage with urgency, meaning one cannot make it to the bathroom in time. Again, this is a universal problem that happens to all people, men, women, with or without spina bifida. And then there's mixed incontinence, which is leakage of urine associated with urgency and also with exertion, effort, sneezing, or coughing. And it is very common for spina bifida patients to have both. So treatments for stress incontinence include conservative measures, Kegel exercises. This works in some patients, but not. Some lifestyle changes, for example, monitoring your fluid intake. Pelvic muscle physical therapy. It's like the difference between doing exercises on your own versus doing exercises with a personal trainer. And some patients use what's called an incontinence ring. This is an incontinence ring. This is particularly useful in some younger patients or patients who are not surgical candidates or patients that don't leak a lot. They only leak when they exercise. If that's the case, then one can put in this ring, the knob goes at the front and supports the urethra. It can be taken in and out by some people. Surgical treatments for stress incontinence are overall for patients with and without spina bifida, a mid-urethral sling, which means a mesh sling, an autologous fascial sling, which is usually the choice that I would pick in spina bifida patients because I don't really like to put mesh in if you might be catheterizing. Urethral bulking agents, which I'll explain, are birch, and then finally urinary diversion, and in some rare cases, bladder neck closure or reconstruction. This diagram illustrates sling surgery. So first we make an incision above the symphysis and we harvest something called fascia, which is a tough lining on top of the muscle. We take the sling, we cut it, we close that area, and then we pass the sling underneath the urethra. This is an example of an injection of urethral bulking agent. We look inside with a camera. We then take a tiny needle through the camera, which is called a cystoscope, and inject some material around the urethra. The most commonly used agent these days is something called Bulkamid, which is mostly water. It's a water gel. Treatments for urgency incontinence include conservative measures, medication, and procedures. So conservative treatments for urgency incontinence, one of the most effective measures is actually increasing the frequency of clean intermittent catheterization. There are many patients that either don't catheterize, but probably could be, or they don't catheterize very often. And oftentimes the patient will have a bladder contraction when the bladder is very full. So increasing the frequency of clean intermittent catheterization often does help. There can be pelvic floor physical therapy, but this only works if the incontinence is super mild. And there have been studies in spina bifida patients in a technology called PTNS, or posterior tibial nerve stimulation, which is the diagram over here. Basically, a tiny needle is placed into a nerve in the ankle that goes to the bladder, and this nerve is stimulated once a week. There are many medications for urgency incontinence. Many of you may be taking these medications. The oral antimuscarinics and the beta-3 agonists, they relax the bladder to give the bladder a better capacity and to inhibit unwanted contractions. Oftentimes, however, in spina bifida patients, one also has difficulty emptying, and so this has to go along with clean intermittent catheterization. So then there are procedures for urgency incontinence. One very common and very effective procedure is injection of Botox or Xeomin or Dysport, botulinum toxin. This is often done in the office or in the operating room with a little sedation. We look inside with a cystoscope and inject the medication into the wall of the bladder. Another option that's a little more experimental but has been shown to work in some patients is something called sacral neuromodulation. And I'll explain that in a little bit. Augmentation cystoplasty works particularly for people who have small bladders. This means making a little cap of bowel and sewing this to the bladder to give it a better capacity. And another option is urinary diversion, which we'll talk about as well. Usually this is an ileal conduit, meaning a little tube of bowel that carries the urine to the skin to a bag. So here's a diagram showing the injection of Botox into the bladder. We usually choose several injection sites and inject it throughout the bladder. This diagram shows sacral neuromodulation. So basically, we usually do a test either in the office or in the operating room where we thread a tiny little needle and a wire to the nerve that goes to the bladder. We then have the patient test out the wire to see if it improves their symptoms. And if it does, then another week we put in the permanent wire with a battery pack. This diagram shows an augmentation cystoplasty. As you can see here, we take a loop of bowel, we open it up, we create a little cap, and we sew it to the bladder. Next, I'm going to talk about recurrent UTIs, which is a super common problem in all women, but also particularly in patients with spina bifida. So recurrent UTIs are 3 or more UTIs in 1 year, or 2 or more UTIs in 6 months. In general, even any healthy woman can have UTIs, but this is the definition of sort of more bothersome UTIs. As well, any patients who have fevers with their UTIs or kidney infections are considered to have problematic urinary tract infections. So management of recurrent UTIs. Number one, if you start having UTIs and you haven't before, you should visit your urologist for an evaluation. The reason this is important is that there may be some contributing factors that need to be treated. Common causes include stones, mucus, worsening incomplete emptying, and sometimes it's as simple as inadequate fluid intake. So the evaluation for recurrent UTIs includes a history and physical exam with your urologist or physician, a urine sample for urinalysis and culture. It's important sometimes to see if you're growing the same bacteria or different bacteria. Radiology studies such as ultrasound or CT scan, cystoscopy or pouchoscopy to look inside and look for tumors or stones, urodynamics, and a bladder diary. Conservative management, so certain things that you could just do at home yourself include increasing fluid intake, cranberry, D-mannose, and in postmenopausal women, one good option is topical estrogen, meaning estrogen cream or suppositories. So in terms of what to do to prevent UTIs, if you're doing clean intermittent catheterization, you may need to catheterize more often. The longer the urine sits in the bladder, the longer the bacteria have to multiply. Anyone who does intermittent catheterization will always have some bacteria in the urine. In fact, a culture will always be positive, but the longer the urine sits there, the more likely it is to multiply and cause an infection. Many patients have to irrigate with sterile water or saline. You can see in this picture a piston syringe. So what happens is the patient will draw up some fluid, either saline or water, pushed in through the catheter into the bladder pouch, and then draw back to remove any mucus or any sediment at the bottom of the bladder. And some patients who have really recalcitrant UTIs need to instill antibiotic solution every night before bed. There are some medications to help prevent UTIs. Methenamine is a medication that turns the urine acidic. It does work better with vitamin C. As I said before, some patients actually have to put an antibiotic solution inside the bladder or pouch before bedtime. And rarely, some patients do need low-dose antibiotic suppression. We prefer not to do this just because over time, patients can have side effects and the antibiotics can become ineffective for the bacteria. Next, I'm going to touch on female sexual health in spina bifida. So sexual dysfunction is a very common problem in women with spina bifida. There are not a lot of studies, but in one good study, 140 women with spina bifida were given a sexual function survey. 83.4% reported sexual dysfunction. Sexual dysfunction was higher in patients with urinary incontinence and highest in patients with both urinary and fecal incontinence. In spina bifida women, there are some very small studies looking at the incidence of the problem, but unfortunately, there really are not studies looking at the treatment. And that is also true a little bit of sexual health in general in women versus men. So there are many reasons for sexual dysfunction in spina bifida. One is thought to be neurological. There's a disruption of the pathways involved in both arousal and orgasm. Some patients may have body image issues, and some patients may have pain and discomfort. There are also sometimes physical limitations. So up to 23% of spina bifida women report problems with lubrication, and up to 63% of women report problems with orgasm. As well, up to 10% report problems with pain. There are some medications for female sexual dysfunction, which I will describe. There are two main medications on the market. One is called flibanserin or Addy, and the second less well-known one is called bremelanotide or Vyleesi. So Addy is an oral tablet that is taken every single day, once daily at bedtime. However, there are some pretty serious adverse effects. For example, severe low blood pressure is one of them and is a little concerning. So at first, the manufacturers said that it was not advisable to drink any alcohol, but now the instructions are that there should be concern with drinking any alcohol within 2 hours. So if one drinks alcohol within 2 hours, the dosage should be skipped, and it should be skipped when consuming 3 or more drinks. Other side effects include dizziness, sleepiness, nausea, and dry mouth. And overall, despite these side effects, the effectiveness is only 10% really, and this is in all women. 10% more patients treated with Addy versus placebo reported some meaningful improvements in sexual function. The second medication is called Vyleesi. This is a self-administered injection into the abdomen or thigh at least 45 minutes before sexual activity. Again, there are some pretty severe side effects. Up to 40% of people have nausea. You can also have a flushing, injection site reactions, headache, and vomiting. The effectiveness is overall pretty low. Approximately 25% of patients who took the medication had an increase in sexual desire versus 17 who took the placebo. So there's a very, very slight increase in sexual desire. So overall, there's not a whole lot out there for advice for the management of female sexual dysfunction in spina bifida patients. Since we know that there is problems with arousal, it's important to spend more time on foreplay arousal. We know that there are problems with lubrication in many patients, so it's important to try to use some water-based lubrications. It's important to try to explore different positions. And overall, for the future, for everybody, it's important to participate in research studies. Thank you very much for this opportunity from the Spina Bifida. I would like to thank the Spina Bifida Association for this opportunity to present, and I will turn the microphone over.
Thank you so much for that. Actually, I learned some things myself, so that was great. I hadn't heard of the other medications for sexual dysfunction. Let me share my screen here. So I was asked to talk today about kind of what a generalist OB-GYN can do for folks with spina bifida. We had reports from several people who had mentioned in our spina bifida clinics here in Albany that they didn't really see the reason to see an OB-GYN. They aren't having kids and there was just no reason to do it. So I wanted to kind of go into a couple of the small things that we can do for you and help improve your overall quality of life. Just no financial disclosures or incentives. So as an overview, we know that people with disabilities in general are less likely to undergo routine screenings for cancers and other long-term health conditions like cervical cancer and breast cancer, even though these are still being recommended by national guidelines. And there's a number of barriers to care, including lack of accessible facilities, difficulty with positionings, patients' fear about discomfort. And then, of course, there is also the stigma surrounding people with disabilities being assumed to not be sexually active. And so oftentimes people will not provide contraceptive counseling or sexual health counseling for patients with various kinds of disabilities. And so I just wanted to review some of the recommended screenings that are recommended for everybody who has a vagina, uterus, and cervix, and some of the other smaller quality of life things that we can help with as well. So starting out with just recommended screenings to be done by an OB-GYN. So the biggest one is cervical cancer screenings. So Pap smears are recommended for everyone with the cervix, regardless if they have sexual activity. And it's recommended. So this is a picture of a speculum exam. And a lot of times people get confused between what a speculum is and what a pap smear is. The speculum is that duckbill thingy that we use to visualize the cervix. And then the pap smear is actually the test that we're using to sample the cells in the cervix. So we recommend this for every 3 years for patients under 30 and every 5 years for patients over 30 with HPV testing. So HPV is human papilloma virus, and that is the virus that we we know that is necessary to develop cervical cancer. So, and we recommend doing that at that frequency until people reach the age of 65. And then there's some exceptions to that rule based on other health conditions. Also, this is a plug for getting the HPV vaccine. I think pediatricians, at least in our area, have been doing a really good job of getting our patients vaccinated as part of their childhood vaccination schedule. But people who weren't, 11 to 13 when the HPV vaccination came out, like myself, can get it actually up till age 45. And this protects against 9 different kinds of HPV. And has really shown internationally to reduce the rates of cervical cancer. So super important. And if you've never gotten it, it's definitely something to ask your OB-GYN or your primary care doctor about. And I wanted to touch a little bit about positioning because I think a lot of people, not just folks with mobility issues, but anybody with a history of trauma, et cetera, a lot of people have understandable concerns about being positioned in a certain way on the table and being very vulnerable in terms of the exam. So there are a bunch of different kinds of positions that we can use to help see the cervix and do the pelvic exam and pap smear. And these are just some examples. And so when you're going to see an OB-GYN and you may or may not have some difficulties with mobility, definitely ask your provider about different positions for the speculum. So, you can do this kind of frog-like position. If you have a lot of spasticity, you can, have people support your legs, but keep the legs straight. Bunch of different options. We can get creative and figure out an alternative way. And then also before you go to your appointment, if you need assistance in getting onto the exam table. So if you're somebody who needs a Hoyer lift, asking before going to the exam room or bringing somebody with you who can help you with that. And then also knowing that if you have a lot of anxiety surrounding pelvic exams for whatever reason, or if you have issues with spasticity, many people, including myself, will provide options for sedation or pain management. So, and that can be performed in the office or sometimes under a deeper sedation in the OR. So these are all options for people. And I hate to see, especially patients with spina bifida or other kinds of mobility issues, I hate to see them avoid the gynecologist because they're afraid of pain, discomfort, or have trauma surrounding previous pelvic exams. So I just want to make sure that people do know that there are a lot of options, and to be a good advocate for yourself if you're seeking care for pelvic exams. So that's enough about cervical cancer. This is kind of our other basic screenings that we recommend for everybody. So breast cancer screening is very important. Most people are aware of mammograms per ACOG, which is the American College of Obstetricians and Gynecologists. We recommend yearly mammograms starting at age 40. There's different intervals and different age cutoffs depending on which society guidelines that you look at. But since I'm a gynecologist, I recommend starting at age 40 and going every year, and then having a discussion about when to stop that. Usually it's around age 75, but it's an individualized discussion with people. Colon cancer screening is obviously something that I personally don't do, but I'm a big advocate for getting people referred to get their colon cancer screening and setting them up. The new guidelines now state that we should be screening people at age 45 with colonoscopy, which is every 10 years, even though it's unpleasant. There's a less invasive test called flexible sigmoidoscopy. That's every 5 years. And then there's the Cologuard, which is a hemocult. And then you would do that annually. And more people are, I think, opting for the Cologuard these days just because it is less invasive. but it is less sensitive and specific than the colonoscopy. We also recommend osteoporosis screening for those at 65 or older. And also if you have any other risk factors like chronic steroid use, this can be really important, as we know that people who have osteoporosis are more likely to have pathologic fractures, specifically hip fractures, and that can greatly reduce longevity and very much increase people's morbidity and mortality. So definitely a big proponent of osteoporosis. Interestingly enough, even though we always tell people to supplement with calcium and vitamin D to help prevent osteoporosis, there was a new study that came out that said that actually doesn't affect your risk for osteoporosis. So good news, you can save yourself some money by not buying a bunch of vitamins at the store, because they're not really helping you anyway. So it's a plug for that. And then literally anybody who walks in my door, I ask if they want to be screened for STIs. If you have discharge, do you want to be screened for STIs? Does your knee hurt? Do you want to be screened for STIs? Do you have a toothache? Do you want to be screened for STIs? So, and these are kind of the grand list of all the things that we can test for. And if you're sexually active and you're not using a kind of barrier contraception, then I highly recommend getting tested frequently. Also, kind of in keeping with the idea that folks with disabilities are frequently not told about their full birth control options and assumed that they are not sexually active, these are a number of different kinds of birth control options that are available for people. And these can they all have their risks and benefits, and definitely something to discuss if you're someone who's sexually active and not interested in being pregnant. I love talking about birth control. I think a lot of gynecologists do. I could do a whole talk about this, but we don't have that much time. So definitely something to ask about for people who are not interested in becoming pregnant, who are sexually active. And then menstrual management, kind of getting away from screenings. Menstrual management is something that I see fairly frequently when I'm seeing patients with various kinds of physical disabilities, including spina bifida. And heavy menstrual bleeding can be really challenging for people to manage, especially if you already have some mobility issues or incontinence issues like Dr. Chung was talking about. And we have a bunch of different kinds of options for managing menses, especially if you're somebody who's not looking to get pregnant either ever or in the near future. So we have a number of different kinds of hormonal medications that we can use, as well as a medication that can be taken on an as needed basis called tranexamic acid, and that helps with bleeding as well. And I always want to encourage people that if they are having changes in their menstrual bleeding for whatever reason, that they should be seen by a gynecologist, because that can often be the first sign of something like endometrial cancer, which can of course be very dangerous for people. So a big plug in that, if you have some changes in your bleeding patterns, definitely bring it up with your doctor, because we may need to do some further investigation on that. And then there are also long-term options for menstrual management if you never want kids. Things like an endometrial ablation, which is where we sort of, for lack of a better term, we microwave the inside of the uterus and burn off the lining that regenerates every month. And that can decrease or even eliminate periods. And hysterectomy is also an option. Some of my patients with spina bifida or other physical disabilities opt for hysterectomy. They know they don't want kids and they don't want to deal with the bleeding every day. So that's always an option for people if they kind of know what their future childbearing goals are. But really overall, just a plug for, we know as gynecologists that bleeding can be really challenging for anybody. And so something to bring up, we're happy to talk about this, and there are a number of different options that people can explore. And then the last thing I wanted to touch on is menopause and aging. A lot of people are confused about menopause. We spend a lot of time in school learning about sex ed and like starting your period and what to expect from that, but not a lot about what happens when it stops. So the definition of menopause is actually having no period at all, no bleeding at all for a whole 12 months. So that's how we define it. There's no test that we can do really that says like, yep, you're definitely in menopause. This is how we define menopause, is just no bleeding for 12 months. But as many people know, you can have kind of off and on bleeding, changes in bleeding patterns as you're getting older. And you can have some associated symptoms with that: hot flashes, mood swings, night sweats. And those can take a long time to disappear, and sometimes even persist after you stop having any bleeding. The average age of menopause in the United States is 51, but people vary, and it can take up to 10 years on either side of that age to fully go through the menopausal transition. I'm especially sympathetic to this because my mother was on the very long end of the menopause spectrum, and I heard about every single day of it. So definitely a big plug to think about it in terms of talking to a gynecologist. And there are some things that we can do. I hate watching people suffer for years and years because they either are embarrassed about bringing up the hot flushes and mood swings, or they just don't think that there's anything that we can do about it. But there's plenty of things that can be done. One is just conservative management, dressing in layers, having fans, kind of common sense things to deal with the hot flashes. But there is hormone replacement therapy that can be good for a lot of these systemic symptoms and can really be life-changing for people. It's overall very safe. A lot of people worry about estrogen, and they've seen some of the older studies about possibly increasing breast cancer risk and those kinds of things. But for a lot of people, especially for short periods of time, hormone replacement therapy can make huge differences in quality of life, and also are very safe if used appropriately. So things to think about, and again, bring up with your GYN. And there are also non-hormonal medications for people who are not good candidates for hormones, like people who have a history of breast cancer and so forth. And those can be very helpful as well. So lots of different things that can be done, and working with the GYN can be really helpful for managing these things, because it's not just about, we don't just do babies. We want to help your overall quality of life throughout your whole lifespan be good. And then Dr. Chung also discussed this very briefly about talking about vaginal estrogen to help with the vaginal dryness symptoms that people can get. This can be problematic both for recurrent UTIs, but also just for sexual satisfaction. So water silicone-based lubes are very helpful, but vaginal estrogen, which this is an example of a bottle of vaginal estrogen at the top that can be inserted into the vagina a few times a week, is not contraindicated in people with breast cancer. So people with a history of breast cancer or blood clots can take this because it's not systemically absorbed, and it can be hugely effective for increasing sexual satisfaction just from the dryness perspective. And then loss of libido is common as people get older, and that can be for a number of reasons, both physiologic and just psychological. Like if you're having vaginal dryness and it hurts when you have sex, then you don't really want to have sex anymore. But also just general loss of libido. Dr. Chung talked about a couple of medications that can be used for that, but also testosterone therapy is being discussed a lot. There's not a lot of research on it currently, but we're seeing some good results with it locally. So something to consider as well. These are just some other resources from the American College of Obstetrics and Gynecology about healthy aging and reasons that you would want to see an OB-GYN. I'm not sure if y'all will have access to these slides, but I'm happy to share them. And that's all I have. And I will pass the mic back and happy to answer any questions if anybody has any.
Thank you guys so much. I know we do have another session starting at 3, so I am not sure if we're going to get kicked out at some point. So I have a list of answered and unanswered questions from you all in the chat. And what we'll do is we will pass along our question list to Dr. Chung and Dr. McLeod and get those answers to you as part of our follow-up. While we're still here, I can start with one of the questions that came in that we have not had answered yet. If my OB says I don't need to see, or if my doctor says I don't need to see an OB because I am not sexually active yet, is that true?
So it depends on what if you have questions about, if you have questions, we're happy to answer them. If you're not sexually active, but thinking about it at some point, it can be really helpful to see an OB. Or if you just want to know kind of more about different kinds of cancer screenings, we do recommend that people start getting pap smears at age 21, regardless if they're sexually active or not. So those are all good reasons to come in and chat with us.
Awesome. And then a follow-up question. If you have an OB-GYN who wants to do, where to go? Annual, they want to do a PAP yearly. How do you advocate for yourself to not do it yearly? I'm 38 years old.
That's always tricky. And there was a time period where we did do that. And sometimes people haven't updated themselves on the most recent guidelines. But you are in control of your body, and people cannot do any kind of pelvic exam like that if you are not consenting to it. So I think the biggest thing is to say, hey, I heard that you're only supposed to do these every 5 years, and have a conversation with that. And if they are really insistent about it, you might want to find a new GYN.
Okay. So I did just see our note from our host that the next session is going to take place in the main room shortly. I just want to thank you both again for giving us such helpful information on such important topics that are not talked about frequently enough. So thank you both so much for being here today.